think if you're one little voice, lone voice in a big, big world, it might be difficult to drive an agenda. But if we come together with an agenda that is critical to all of us, and I think maternal and child health is critical to a lot of partners, then we can really champion this agenda, not just nationally, but regionally and globally.
My name is Apoorva Sharan.
Dr. Minnie Kibore.
I am the Senior Manager for Health and Nutrition at CIFF India.
I am Senior Manager for Maternal Child Health and Nutrition at CIFF Africa.
I'm an epidemiologist by training.
I am a pediatrician and a public health expert, and I'm really happy to be speaking to you about this really, really important topic today.
What does your approach to health look like in Africa?
I'll give you a good example. We have a program, quite a large program across 10 African countries called the Beginnings Fund, which is accelerating maternal and newborn survival. As you may know, Apoorva, Africa has the highest rates of maternal and neonatal mortality. And those have been two indicators that have really stagnated for quite a long time. And there's a huge push across the African continent among leaders, among governments, among regional bodies to drive down the rates of maternal and neonatal mortality. So in that light, we came together with other funders, like-minded funders, to create a fund, a pooled fund, that instead of, all of us implementing our individual solutions by ourselves, we have come together to implement solutions together.
That's great to hear, Minnie. Can you share some details of how you implement that approach in your work? How do those lead to better lives for children?
In Beginnings Fund, we co-design the plans with governments. We sit down with governments, we understand the challenges that actually have led to poor maternal and neonatal indicators, and we design a package of interventions that addresses the key challenges for that particular country. So 3 key principles that really drive our work in Africa. We have a key principle of co-designing with governments, and we have to implement solutions that are relevant to the communities that we serve. The other piece is working with ecosystem partners. We have, mapped our ecosystem partners right from the community level, the CSO level, all the way to sub-national and national partners, and global and regional entities that actually support the work that we do, and that we're actually working together to complement each other, to collaborate together, and to actually drive impact together. The other key piece is we are working with countries to ensure that we co-design with them. They lead the co-designing process, they own the co-designing process, they own the solutions, and ultimately that makes sure that the work that we are doing is actually grounded in government systems and structures and is sustainable for governments. So those are really the key pieces that I'd say we use as Africa. And I'd like to hear from you, Apoorva. How does our approach in Africa compare to the work that you're doing in India?
Minnie, I think that there are many similarities with the approach that you've described. In India as well, a key part of our work is to align with the goals that governments have already set out for themselves. So, for example, the government of India has laid out an ambitious vision document, which is called the Viksit Bharat Roadmap to 2047. And we know that in order to achieve that vision, it is critical that we make advancements in women's and children's health and well-being. As you've highlighted in CIFF Africa, data and evidence generation plays a critical part. So a good example of this would be the Rajpush program that CIFF had supported in collaboration with the state government of Rajasthan and development partners that are local to that state. Essentially, there are existing direct cash transfer schemes that help pregnant women prioritize their nutrition. What was missing is targeted social behavior change communication, which was informed by local case studies that helped us better understand how decision making around food choices are made in diverse populations in the state. When we coupled and layered on this intervention of the direct cash transfers with targeted social behavior change and tried to improve the service delivery of the cash transfers, we found remarkable results. We were able to improve dietary diversity. We were able to ensure that cash is utilized specifically for improving nutritional choices among pregnant women. And in fact, this was cited in the recently published National Economic Survey as a best practice. So the government recognized also Direct cash transfer schemes should be coupled and layered with improved service delivery and tailored social behavior change communication to maximize impact on health outcomes.
That's amazing, Apoorva. And based on your experience, where do you see the greatest opportunities for advancing health in India are? And how do the specific local challenges and contexts really impact these opportunities?
So Minnie, as you know, over the past 3 decades, India has actually made a lot of improvement when it comes to improving the lives and health of our mothers and children. We've been able to reduce maternal mortality by over 80% and reduce under 5 mortality by close to 75% in the past 3 decades. So what that means is that broadly we are on track to meet our SDG targets when it comes to health. With this growing development, there are also 3 key opportunities that I see specifically. First, I know that India has growing capability in technology, research, and innovation. The second key opportunity is we have deep capacity for manufacturing not only drugs and chemicals, but also health products and digital innovations now. When India introduces a new product within its own public health system or supports its manufacturing through generics, it drives the cost down and it enables many other countries to access those same products and innovations. And the third and key point is we are also seeing there to be a growing potential for domestic philanthropies to contribute to improving health and nutrition of communities in India. Minnie, same question to you. How do the varying contextual nuances across Africa shape your work?
We have learned quite painfully in some instances that sometimes if you do not pay attention to the local cultural and social context, you will find that you have an amazing intervention that has very poor uptake. For example, we found that scaling up maternal prenatal supplements, MMS, in some countries you find that the packaging may be similar to other drugs that maybe have a certain stigma, and therefore you find that the women don't want to take it because they'll be thought to be taking some other intervention. So you have to then go back into the countries and make sure that as you're building the intervention, you contextualize whatever intervention that you're going to roll out, for example, in this case, maternal prenatal supplements, to that local national context. And Apoorva, how can philanthropy help to build the scaffolding to deliver impact to our partners?
So I'll give you an example of how philanthropies can play that role. And essentially, it is to start with small proofs of concepts where we test out our hypotheses, where we are able to de-risk innovations because philanthropies can act with much more agility than other larger public health systems. And we can pilot newer ideas in smaller geographies, engaging deeply with the communities where we work with and also with local partners to enrich our understanding of not only the problem but also the solution that we intend to design. One of the ways that we did this was in a program which is called the Dakshata program. With our proof of concept and the subsequent scale up that CIFF had also supported, we were able to demonstrate what really works and what needs to be tweaked further to improve the quality of care that is provided to pregnant mothers during their delivery and also to newborn babies. So, Minnie, I'm really interested to understand how do you work with partner ecosystems in Africa to scaffold solutions?
There's a famous African proverb that says, if you want to go fast, go alone. If you want to go far, go together. As CIFF Africa, we are engaging our ecosystem to scale locally led solutions. Now, our mission is on ending preventable deaths of mothers, newborns, and children under 5. It's a big, huge mission that cannot be driven by one partner, by one organization. And therefore, we realize the need to actually ensure we work across the ecosystem to make sure that we drive interventions and implementation all the way to the last mile. For one, like I said, we have an integrated systems-led approach. One of our programs, another program that we implement is called Nest 360. It's a newborn survival program. And what Nest has done is ensure that we have that equipment available for countries to use that is robust enough for the local setting. And when I say local setting, our setting sometimes is humidity, there's dust, there's power surges, and those cause, some very, beautiful equipment that is not really set up for the low and middle income setting to fail. So they develop equipment or approve equipment that is relevant for our setting. And beyond the equipment is ensuring that this equipment is maintained, that the local engineers, the local clinicians actually know how to use it and how to maintain it, and that the countries actually know how to plan for the commodities for this, not just for the equipment only, but also for all the other work that's required.
What is the evidence telling us about what works best, and how do we make sure that leads us? Do you have a retrospective process to ensure lessons are learned from your projects?
We anchor our investments in evidence and data. But it's not just enough to conduct research into what works. And at CIFF Africa, we are really now laying down the solid tarmac to make sure we get to scale through system change. We believe system level means that a solution, and when I say system level, it means a solution is embedded in national systems, in national policies, budgets, and supply chain, workforce, and data, owned by the government, and viable even without external funding from CIFF. So while we might provide catalytic funding to put the systems in place, to support governments put the systems in place, provide some technical expertise, the ultimate goal is to make sure that these systems can run without external funding from CIFF. So we've moved from pilots to platforms. And that is really anchoring innovations in routine platforms and not in parallel systems. From a CIFF Africa perspective, we've also moved from short grants to sustainable financing. We realize that it's very difficult to plan for sustainability with short grants. And therefore, we are really moving into budgeted multi-year domestic and blended financing projects. And what about you, Apoorva? How does that work for you?
Minnie, I think, again, a lot of similarities between the Africa approach and the India approach. Evidence is really central to how we work, right? And one of the ways that we make sure that this evidence leads us is by developing continuous learning loops, as you were mentioning, having really tight evidence to action cycles. And I'll tell you some real world examples of where we've seen that really have a significant impact on our programming and the impact we're able to deliver. In the Rajpush program in Rajasthan, which was about delivering direct cash transfers to pregnant women so that they can prioritize their nutrition, and we had layered along with this improved service delivery and social behavior change communication. Well, do you know where the improved service delivery component came from? It actually came from our learning on the field. Because what we knew is that there are direct cash transfer schemes that are available at both the central and state government levels, specifically for improving maternal nutrition. But when we went to the field, actually this learning is coming from our partners, what we observed was a major barrier in pregnant women actually enrolling into these schemes were the paper-based forms and the administrative complexity. So the solution that came up through an iterative process was to make this enrollment an automatic process and to make it digital. So we take away the intimidating paper forms that pregnant women have to fill in order to enroll into these schemes. And how do we do that? By automatically linking this to the antenatal care visits that pregnant women routinely make in public health settings. So this was actually a real world lesson that we learned when we first started programming for improving maternal nutrition, and it helped us really expand the coverage. So in many ways, I think evidence becomes a continuous feedback loop, helping programs improve as they expand in their implementation.
What about scale? How do we move beyond direct impact at the local level, taking our learnings from proof of concept to create system level change?
There are a few ingredients that help innovations go from labs or from a few select pilot districts to nationwide scale-up. I think the first one is having a mission-oriented approach. So as you've mentioned, co-locating interventions within the same geography and working to saturate all of the streams where we can deliver services to address a common problem or taking a mission-based approach is critical. A good example of this work is the Born Healthy initiative, which started in a few districts in a few states and is now in the process of scaling up. Now, this work focuses on strengthening the quality of antenatal care that is delivered to pregnant women. And what we learned is that improving quality doesn't just mean training frontline workers. It also means building confidence within the system and amongst our beneficiaries through supportive supervision and mentoring visits. It requires piloting digital innovations that can reduce the burden on frontline workers so that they can focus more on patient care and less on administrative responsibilities. And by constantly feeding all of the lessons we are learning in the field to improve our programs, we're now at a point where we are ramping or rolling out the Vatsalya Born Healthy scale-up across the country in additional states and districts.
Really amazing work on scale you've done in India. What about you, Apoorva? What learnings and successes could be useful in other geographies around the world from India?
I think one lesson that travels well across geographies that we've learned through our work in India is solutions work best when they are designed keeping in mind or at the center of the solution the people that they are meant to serve. It's not socioeconomic status of the intended user, it's not gender, it's not digital literacy. Essentially, what we are seeing over and over again is that two factors dominate whether public health systems adopt or reject digital interventions. One, whether it is something that the intended user thinks to be useful, so their perception of its utility essentially, and their ease of use.
And I think we can learn from evidence generated in either setting to build on it instead of starting from scratch. Build on it, contextualize it for implementation, creating blueprints for countries or regions to adapt without the cost and the time spent building an evidence-based or implementation plan from scratch.
I completely agree with what you're saying. I think with every investment, apart from publishing the technical results, the key wins that we've been able to achieve, we should also try to publish a blueprint that captures all of the tactical operational details. What did we learn? What did actually we learn about things that don't work in the field? What nobody should try again? So things that really break down the operational experience of rolling out large-scale public health programs, but in bite-sized pieces.
Thank you, Apoorva, for this conversation. This has been really enlightening.
And thank you, Minnie. I'd love to talk to you more often.